So Lance Trexler here, starting the webinar for today. Hope you can hear me okay. If someone wants to just send me a chat message to confirm that you can hear me okay, that'd be great. And I have with me today also Dr. Summer Ibarra, which I don't think most of you have met, but you will be meeting her. She's very much, thank you, Denise. Appreciate the message. Dr. Ibarra is getting very involved as our new Associate Director for Resource Facilitation. Hey, Jim, glad to hear you're on board. Hi, Tina. Thanks for joining us today. So today we're going to talk about concussion and mild traumatic brain injury. And actually, I did a seminar on this about a year ago, but there's been some new guidelines developed based on evidence-based reviews that I wanted to share with you folks because it does make a difference in terms of practice. And whether it's a VR client or simply someone you know, I thought it'd be information that would be valuable and important for you. And we'll talk about some of the vocational issues for these patients as well, of course. But yeah, there's a lot of new information. I'm sure you're aware of everything that's going on in the media. Hey, Marcia and Steve, thanks for joining. Good to see you on here. There's so much going on in the media right now with respect to concussion, and I think people are finally starting to pay attention to this issue and the long-term the long-term potential consequences. So anyway, that's the background on this. I've got a bunch of other webinar topics coming up, and for those of you that have been around for a while, I just wanted to share with you too, we're going to continue these webinars on a quarterly basis, on a go-forward basis indefinitely. And one of the questions I'm always interested in asking you guys is topics you want. So if there are particular topics you're interested in for future webinars, please fire them out through the chat option or send me an email. So anyway, and hello, Marianne and Roger. Thanks for joining us, and Renee. So we'll get started here. First, we're going to just give you kind of an outline here. We're going to talk a little bit about the incidence and definition of concussion, mild traumatic brain injury. For those of you that are new to this topic, concussion is a brain injury. And so I think it's important to start off with that kind of perspective. Hi, Karen. We'll talk a little bit about the pathobiology of concussion and mild traumatic brain injury. Briefly talk about neuropsychological examination, diagnosis, and the course. And we'll talk about the new evidence-based guidelines that are out. That's something that I really want you guys to be aware of. So in brief, you folks have seen, some of you folks have seen these data. 1.4 million every year, traumatic brain injuries. That's 4,000 a day, guys, which is every 3 minutes. It's just kind of a staggering statistic. At least it always is to me when I see that. And you see that it represents about 1,300,000 ED visits a year, with 52,000 people dying, 275,000 are hospitalized. And what those data obviously imply is that it is the majority of these TBIs are fortunately classified as mild because of the rates of hospitalization. The CDC just came out with new data on causality, and so it used to be that the majority was caused by motor vehicle accidents. That's not true anymore. There is now a larger percentage of people with falls, and this is occurring because obviously our population is aging and living longer. So now what we're seeing from an epidemiological standpoint is, oh, so Laura, I see your note here in the chat that you have no sound. Do you want to see if George is available, Summer, to see? We're going to see what we can do, Laura, to help with that. I think everyone else has got sound, so I'm not sure why that would be. We've got someone here that's got no sound. I don't know. I think everybody else is okay, but
they might have headphones, or if they have speakers of so a lot of the computers there.
Okay. So the suggestion, Laura, is maybe try plugging some, this gentleman is suggesting if you can plug some headphones into the computer, or what else did, or there was...
Can they call in?
Or can you call in on the telephone line? I don't know if you have that number, Laura.
And she can't hear us talking to her.
Oh, that's right. Of course she can't hear us. Yeah, so...
I don't know if you can type it in.
I haven't the foggiest idea.
Oh, yeah.
Probably down there.
Jim, someone send Laura a message, if you would, to try the dial-in number. That would be great, because of course she can't hear what I'm saying. So.
Oh yeah, so it shows who's typing, or I think it allows you to put a little message.
Yeah, maybe it does. Yeah, but Jim got it. Yeah. Thank you, Jim. Appreciate it, guy. So anyway, so thank you, Shell. So yeah, and we're seeing this at RHI too in terms of our inpatient hospital admissions, that we're getting more and more older folks that are trying their best to be independent, and they go out and clean the eaves troughs and take the fall, or they're putting something up in their garage and whatever. And this is an issue. Fall prevention in the elderly is going to be a big deal in the next few decades here. But anyway, so and of course we have those that are assaulted. We have those that hit something one way or another. 21%. Hello?
Hello.
Yeah. Sorry. Who is this?
This is Marcy from the VR.
Okay. Yeah, you're on. Okay. Yeah, we're live. Thanks.
Thank you.
So this is kind of the causality, if you will, for traumatic brain injury. Now, as I said earlier, fortunately, 70% of these would be classified as mild traumatic brain injuries, but interestingly, in Indiana alone, that means there's going to be 10,000 a year. 10,000 people each year will have a concussion or mild traumatic brain injury. Of that 10,000, 1,500 of them are going to have persisting symptoms or impairments associated with their injury. And that's the group we're going to spend quite a bit of time talking about today. 15% of those folks are moderate to severe. Yeah, and as I said, 15% are going to have persisting symptoms. Now the classification of severity is based on a variety of variables, including loss of consciousness, post-traumatic confusion, and Glasgow Coma Scale. And it's important for us folks on this side of the call to gather this kind of information because it tells us about the severity of injury, and it tells us, therefore, prospectively how we may want to manage each of these patients because they are different. But it's often the case that sometimes their loss of consciousness will fall into the mild category, but sometimes their post-traumatic amnesia or post-traumatic confusion may fall into the moderate category. So obviously not everyone fits just strictly into one category, but it's really important to gather these data from our standpoint so that we can begin to think about what kind of assessments and what kind of intervention may be necessary, and we'll get into that in detail. But that's the classification system, and in our reports, you'll often see we make reference to mild, moderate, and severe, and at least based on the acute injury characteristics. And so this is where that classification is coming from. But I want to digress a minute, because the other thing you need to know is that a mild injury based on the acute characteristics, that is Glasgow Coma Scale, loss of consciousness, is not well correlated with long-term outcome. So we have patients that have severe traumatic brain injuries that have just recovered phenomenally well and are back to work and doing their thing at 4 or 6 months. And we also have patients that fall into the mild category and are still vocationally disabled a year later, which is one of the things that makes brain injury so fascinating, but also makes it so complicated. It's a nonlinear relationship between initial severity and long-term outcome, and we're going to talk about that in some detail today. So concussion grading is an important issue. So there are several different classification schemes. This one's from the American Academy of Neurology. So you can see there that a level 1 concussion is no loss of consciousness, no post-traumatic amnesia. For those of you who may not know what post-traumatic amnesia is, real briefly, post-traumatic amnesia is the person can be alert and respond to questions after injury, but not forming any new memories. And so a lot of patients will get a mild traumatic brain injury, go to the emergency department, be evaluated, discharged, and they have no memory of being in the emergency room, which is a perfect example of post-traumatic amnesia. So level 1 is no loss of consciousness, no post-traumatic amnesia, but they have a period where they're confused or disoriented. So it's an alteration of consciousness. Level 2 is no losses of consciousness, but post-traumatic amnesia, and that's classified as a moderate concussion. And third, then we have the patient has a frank loss of consciousness, and that's graded as a severe concussion, which is a traumatic brain injury. The diagnostic criteria put forth by the American Congress of Rehabilitation Medicine is extremely similar. So it's at least one of the following to be classified as having a concussion. And by the way, when you look at these criteria, you'll soon realize why 1 out of 10 people in our population have had a concussion. So any loss of consciousness, any loss of memory before or after injury, any alteration of mental status, a focal neurologic deficit that may or may not be transient. So that would be, for example, some mild slurring of speech or mild impairment of ability to feel things on one hand, or weakness in one arm or another, as an example. If the injury, it's a concussion or mild traumatic brain injury, if the severity of the injury does not exceed the following. So if you lost consciousness for more than 30 minutes, then that's not classified as a mild TBI. That's a moderate TBI. After 30 minutes, an initial Glasgow Coma Scale score of 13 to 15, as another example. Or post-traumatic amnesia of greater than 24 hours. So these are the criteria offered by the American Congress. So now let's talk about this issue of pathobiology, and I'll try and make this painless for you. But so in the mildest of cases in concussion, mild traumatic brain injury, it is an acute metabolic physiological disturbance without anatomical injury in the mildest of case. So you whack your head, and the neurochemicals that promote transmission from one cell to another become disrupted. And when that happens, you can't think right. And that's a metabolic disturbance. So we have to remember that this squishy stuff between our ears is an organ that is that is not only based on structure, but it's based on metabolism and physiology. And so an injury to the head will disrupt the metabolic stability of the nerve cell, therefore altering function. So an example of that clinically, and this is what I want you to understand how powerful this issue is, because a disturbance of metabolism is the basis for what is called the second impact syndrome. And I don't know if you've heard about the second impact syndrome, but let me just share with you a patient that I had who was a 16-year-old guy who was playing football, got his concussion, was told to not return to play. He begged and begged and begged and begged his mother to let him go play. She ultimately gave in and let him. He went back on the field and, of course, got another head injury. Unfortunately, a year and a half after that second injury, he was still in a wheelchair drooling on himself. And so what happened was we had a guy with a metabolically unstable brain who then gets re-injured, therefore even making that metabolic physiological disturbance much worse, and then adding anatomic injury on top of it. So the metabolic stability of our brain is a really important issue. So I think we need to regard that as just as importantly as we do a structural anatomical injury that you can see on a CT scan or an MRI scan. We have this idea that if we can see it, it's real. And it's very difficult to see metabolic or physiologic disturbances unless you use very, very specialized techniques like PET imaging or other very complex kind of neuroimaging procedures that aren't available for clinical application at this point. But in the very beginning, these neurophysiological or metabolic disturbances are what cause the early symptoms of a concussion. So only a small percentage of those patients that have a mild TBI concussion will show anything on a CT or an MRI, especially CT. So anywhere between 7 to 20% of patients that go to the emergency department will show something on a CT, either like a bleed or bruising on the brain or swelling. If they do, these 7 to 20% of people with concussion, okay, mild traumatic brain injury, of that 7 to 20%, they are referred to as complicated mild TBI. So it's really important, folks, to know, to have this information, because the truth of the matter is that a complicated mild TBI often presents more like a patient with moderate traumatic brain injury. They have more cognitive and behavioral impairment, and they're much slower to recover usually. The head CT is abnormal in 5% of patients with a Glasgow Coma Scale of 15 at ED, versus 30% of those patients with a Glasgow Coma Scale score of 13 by the time they get to ED. So again, and again, you'll see here the presence of structural abnormalities argue for this causal relationship, and if we're drawn to, if we can see it, then gee, it really must be real. But of course, it's real in the other case too. The metabolic effects of these sorts of injuries, I'm not going to go into in too much detail, but the metabolism inside the cell and the metabolism outside of the brain of a nerve cell are precarious, delicate issues. And the cell membrane is permeable to allow for different kinds of ions to pass back and forth between intracellular and extracellular environment, and that's how it maintains its balance, if you will. But the other issue that's really important is this issue of energy demand and supply. So inside of each nerve cell is a thing called mitochondria. And they are kind of like the biological battery of the cell, if you will. And so it's the mitochondria that are pumping out, that are directing the cell to produce the neurochemicals that are necessary to sustain its activity. And in the case of concussion, mild traumatic brain injury, that cell's capacity to produce those neurochemical agents becomes reduced. And as a consequence, what was once easily tolerated in terms of cognitive or physical activity now becomes totally exhausting for the patient with concussion or mild head injury. And literally they run out of neurochemicals to subserve the activity. And this is, of course, why so many of our patients present with fatigue, cognitively and physically after injury. And again, this is a symptom that the patient will tell you about, but is not easy to, quote, see, end quote. It's hard to see fatigue. So so the other thing that happens is that with concussion, mild head injury, there are changes in blood flow, and as well as in intracranial pressure, and so cells can be influenced by these sorts of changes as well. It's a the brain is ensconced in this cranium of ours, and all sorts of physiological activity influences its functioning. Now, in animals, this lasts for a couple of weeks. Just these metabolic sorts of changes. We don't know how long in humans exactly, but again, this is the basis for the second impact syndrome. There's some new legislation that's being proposed, I think, in the House now, or in the Senate now, to have a minimum waiting period for sports concussions, which, of course, I think is a really, really important idea. Usually in an uncomplicated concussion, mild concussion, the symptoms last for about 72 hours with fairly rapid improvement in young, healthy people without comorbidities or complications. So some of these microscopic changes that can occur. Now we're going to talk about anatomical changes. So these are also physiologic abnormalities. But if you get patients to allow you to do a brain biopsy, which very few of my patients have been willing to do, and look at their brain cells under microscopy, you could see structural and anatomical impairments. So this is an image now of a cell on the top with its long axon coursing through the extracellular environment. And this axon should be straight, but it has been stretched by virtue of an injury. And you can see that some of the intracellular chemicals and organelles are starting to accumulate and get bunched up, if you will, or clogged up in this axon when it ordinarily should be traveling from left to right, from the cell body on the left down to the axon terminals on the right. So this cell is not going to function properly, and therefore the patient is going to experience some kind of symptom. Now, if that stretching is bad enough, then on the bottom cell you see there where unfortunately now these organelles are starting to swell up and causing a frank the transportation system between the cell body and the axon terminals has literally been stopped, and these things are accumulating and forming these what are ultimately called retraction balls. If that continues, then that axon will break in half, and so now you see that the cell axon has literally been broken, and there's this retraction ball. And now we have a non-functional brain cell. So the cell is still alive, but there's no function associated with it. These are things you can't see on a CT or MRI. However, this image shows you electron microscopy in animal tissue of what these things look like. So the little the curved arrows. So right here, I don't know if you can see that. I don't know if I'm doing this right. I think maybe. Yeah, here we are. So these curved arrows point to a normal axon right there. It looks like just almost like a series of little dots. In contrast to this, I'm not doing this right. Well, maybe I am. That is a retraction ball. That's what happens. Here's another one right there. And there's another one, obviously. So those are cells that may or may not still be living, but have been anatomically impaired by virtue of the severity of the injury. So the time course we're not sure about. As I said, in CAT, the axon, these sorts of abnormalities evolve over a 12 to 24-hour period of time. So the implication of that, folks, is that in concussion mild traumatic brain injury, and indeed we see patients who report this, they can get worse, not better, over the first 24 to 48 hours. And that's because, unfortunately, physiological and ultimately anatomical things may be happening inside their brain that actually do impair function. And we don't know how long that period of time is in humans, but we know that in cats it's about 12 to 24 hours. To make matters worse, back to this image, if this cell right here is dependent on the input from this cell that is now dysfunctional, guess what happens to this cell? It just lost its buddy, so to speak. This cell may not have the same connectivity that it used to because its buddy that used to talk to it now no longer can talk to it. Well, there's a process, unfortunately, called Wallerian degeneration, which means that now this cell starts to deteriorate in terms of its axonal, or what we call morphologic, connectivity. So each one of these cells has little tiny branches that connect all over the place to different cells, and if it's not getting input, those those axon terminals or dendrites may start to actually drop off. So this Wallerian degeneration can evolve in animal models for as long as 60 days. So now neurons that weren't initially affected by the trauma begin to function less effectively. So now we have the opportunity, unfortunately, for further deterioration in function. Yeah, and yeah, well, I need to come back to that topic because there's something else that we need to, well, actually, no, I'll just talk about it right now. So I'm going to shift now and go into the chronic stage and now talk about a year post-injury in moderate to severe injury. We now have data coming out of the Traumatic Brain Injury Model Systems program to show that as many as 30% of our people with moderate to severe head injury decline after the first year. So it's not the case that our patients always get better. In fact, sometimes they decline. And this is why, from a brain injury systems standpoint, if we talk about how our healthcare systems and our social service agencies are connected or not, this is why it's so important to proactively manage these patients to try and prevent that decline. But as many as 30% of our moderate or severe patients get worse. And it's not related to Wallerian degeneration, it's related to other issues in the post-acute phase. But it's entirely possible, back to the point here, that over the first 60 or 90 days, there may be some degradation of function, and the patient gets freaked out because they notice that they're getting worse, which of course just scares the heck out of them, which then sets the stage for other psychological problems to emerge, like depressions or anxiety disorders, etc. Now, that's not good news, but the good news is that there is also at the same time a physiological momentum for cellular regeneration. So in fact, our axons can grow new branches to connect up with neighboring cells to compensate for lost connections. So we may have in our brains going on two things at the same time. We may have Wallerian degeneration happening, which is causing a problem, but at the same time, then we may have regenerative activity that's going on to promote recovery. With that said, it's also believed, though, that this regenerative initiative, where cells are remodeling themselves, because you have to remember, these brain cells are plastic. They can morph, they can grow, they can connect up in ways that they weren't before, which is very cool. But on the other hand, if they connect up wrong, then things can happen like seizure disorders. And seizure disorders may be the consequence, in part anyway, of cells hooking up in the wrong way. Certain kinds of visual impairments may be associated with cells hooking up in the wrong way. Anyway, so what we've been looking at in this previous image here, these are all examples of what's called axonal injury or diffuse axonal injury. Because of the tissue density differences in the brain, diffuse axonal injury has a predilection to occur in different regions of the brain, and the most common place for that to occur is in the brainstem. And it's because it's these long axons. These are long cells, and so they're more vulnerable to stretching and tearing, especially since this upper brainstem is encased in this hole in the cranium right here. So it's very easy for that region to stretch when trauma occurs. The other place where this occurs is in the corpus callosum, which connects your left and right hemisphere. And this is why so many of our patients report that they just feel cognitively slow, because the system for passing information around through the brain has been damaged. And so while they may not have an intellectual deficit, they may have perfectly good higher level intellectual functioning as supported by the cerebral cortex. The communication system between the cortices is impaired through corpus callosum diffuse axonal injury. And then you can see some other regions of the brain here that are quite vulnerable too, including the hippocampus, which is why so many of our patients have memory impairment, for example, and around the third ventricle down here. And that's why so many of our patients have attention and concentration problems, because the systems that drive attention and concentration emerge out of the brainstem. So there's an anatomical basis why so many of our patients have the symptoms they do. So let's talk now about the symptoms of acute concussion, mild traumatic brain injury. These are new data, new things that I'm going to share with you now. So in the evidence-based practice of assessment and management of concussion, mild traumatic brain injury, they're now classify these symptoms into three major categories. So obviously the physical symptoms, including headache, nausea, vomiting, blurred or double vision, seeing stars or lights, dizziness, sensitivity to light or noise, and tinnitus. Tinnitus is that ringing sound in your ears. It's quite annoying. Behavioral and emotional symptoms include drowsiness, fatigue, lethargy. Certainly irritability is common, anxiety, depression, sleeping more than usual, and paradoxically difficulty falling asleep. So sleep and wakefulness. So if you think about sleep and wakefulness, so we have this thing called a circadian rhythm, and we in theory are bright and alert by about 9 or 10 in the morning. And then we get a little drowsy after lunch, and that's when I have my double espresso. And then towards evening, then we start to get drowsy, and we go to sleep, and then by 9 or 10, we're fully awake the next morning. So that's a normal circadian rhythm. And so trauma disrupts that. So trauma reduces both ends of that spectrum. It decreases the depth of sleep, and it decreases the level of alertness. And so now people have difficulty sleeping. They don't get a good sleep. They don't go into a deep sleep, and they never feel really awake because of the neurochemical and potentially anatomical changes that have occurred associated with the injury. So that's why, one of the reasons they're irritable, because if you haven't slept for 2 days and somebody wakes you up in the middle of just getting to sleep, you're more than likely irritable, and all mothers out there will have had that experience. And so that irritability often arises based on disturbances of sleep and wakefulness. So anyway, and then the cognitive symptoms acutely are feeling, as you might suspect, slowed down or feeling dazed or in a fog. And then the two big ones are, of course, concentrating and remembering. So diagnostic criteria. So the acute diagnosis of concussion, and you'll see this in a minute, the evidence-based reviews clearly show that people that get an accurate and a diagnosis early have better health outcomes, which flies in the face of the tendency to say, oh, it's just a concussion, they'll be better. Earlier diagnosis using the right criteria and then the right evidence-based management improves long-term outcome. So the good, as you saw earlier, the good news is the majority of these patients will be perfectly fine at 3 months. There's that 15 to 25% that are vulnerable, however, to protracted difficulties. And let me just take that to heart for a second here with respect to the implications from a vocational standpoint. I'm going to share a case study with you, a very brief one. This fellow was a 6 figures kind of executive working in Indianapolis. Typical scenario, guy has a family, some kids, lived in Carmel, Indiana, executive in a major corporation here in town, gets a concussion. I think he was playing racquetball, actually, and I think he smacked his head on the wall or something. Blew it off, didn't go to the doctor, had persisting symptoms. Finally, his wife said, you know, gee, Fred, you're not behaving in the same way. Better go see your family doctor. His family doctor says, oh, yeah, you had a concussion. You'll be fine. So they blew it off, and then 3 to 6 months later, wife is saying, you know what, Fred, I can't stand to live with you anymore because you're incredibly irritable. You forget stuff all the time. He didn't tell her that people at the office were telling him the same thing. He was making bad decisions. This is a guy had about 30 seconds loss of consciousness, to put it in perspective. So by 6 months now, he's starting to have significant difficulties at the job, is forgetting things on a routine basis, is blowing up at his subordinates, losing his temper. Wife says, you know, we got to go see somebody because our marriage is falling apart. He refuses to do so. And long and short of this is this guy was unemployed and divorced a year after a concussion with a loss of consciousness of less than a minute. And on neuropsychological examination, when we finally got him, a year and a half after his injury, he was still clearly impaired in terms of cognitive and behavioral functioning. So this doesn't have to turn out this way. And if we use evidence-based diagnostic criteria and evidence-based assessment guidelines in the appropriate timeline, then we can help a lot of these folks prevent that sort of outcome. So these are diagnostic criteria used in the ICD-9 or ICD-10, sorry, for what they call post-concussion syndrome, which I don't like the term because it's sloppy, but that's what it is. And their diagnostic criteria are as follows. So the usual headache, dizziness, malaise, as they like to call it, fatigue, noise intolerance is really common, and so is light intolerance, or as we call it, photophobia or phonophobia. These are common. Irritability, depression, anxiety, subjective concentration problems, and they say without neuropsychological evidence of marked impairment. So even if they're just subjectively experiencing cognitive problems, then it meets criteria. Insomnia, I don't know where they got reduced alcohol intolerance. Of course, it's true. I don't know where they got that, but it's in there. I don't know, maybe it was based on their own personal experience. And then a preoccupation with symptoms. And many of our patients are preoccupied because they're not getting better, and they're scared that they're never going to get better. And I don't like their comment about hypochondriacal concern, because I've worked with many patients who have, of course, become concerned about their difficulties functioning, and for very good reason. But anyway, those are the criteria from the ICD-10 perspective. And your mental health providers need to be using these criteria from their perspective in ICD-9. The medical providers need to be looking at this from the American Academy of Neurology criteria or the American Congress of Rehabilitation Medicine criteria that I showed you earlier. So these post-concussion symptoms, however, I should say sometimes aren't exclusive to concussion. So many people have headache. Many people have fatigue. Many people have concentration difficulties. And so for example, chronic pain and the medications used to treat chronic pain can cause problems with memory, attention. They can cause fatigue. Depression certainly can affect memory. Post-traumatic stress disorder can certainly affect attention and concentration. So this is why differential diagnosis in the early stage is really, really important. Like everything else in the world, cognitive impairment gets worse with stress. Pain gets worse with stress. Anything gets worse with stress, and that is true of concussion and traumatic brain injury also. Pre-existing psychological factors affect how we respond to concussion. If you tend to doubt your own adequacy and you have fears of failing, and now all of a sudden you can't think right, you're going to respond differently than if you tend to be confident and assume that you'll be able to figure it out. And then sometimes psychologically we can maintain symptoms accidentally because while in the early stages it may be the underlying pathobiology that causes your problems with memory, if you then get depressed because you're freaked out because you've got memory problems, now all of a sudden you get better biologically, but because you're depressed, now you continue to have problems with memory. So sometimes if we don't manage our patients well, or we fail to properly evaluate them well initially, then they have this picture where maybe neurologically they have fully recovered, but psychologically then they continue to have difficulties that affects their ability to function. So again, the need for evidence-based assessment and follow-up. So this is some examples here. So in terms of those ICD-10 diagnostic criteria I shared with you, as many as 81% of chronic pain patients would meet criteria for post-concussion syndrome. That's why I don't like the ICD-10 criteria. So now you could use those criteria and classify chronic pain patients as having had a concussion. And 39% could have been formally diagnosed. And as I said earlier, we have patients out there running around. Many of us have fatigue, headache, and the like. Some of those symptoms being common with concussion. So there is something else important, though, and that is more patients who have persisting vocational disability also had additional injuries besides the concussion. So if the patient had an orthopedic injury or soft tissue injuries, they're going to have difficulties with return to work. So I thought these data were very important for you to know. And again, guys, when the patient walks, when this very patient right here walks into your office, they are going to look as normal as anyone out on the street. You are not going to see any disability in this patient. It literally is all in their head. And if they broke their clavicle, or they had a fractured leg, or they've got a nasty cervical strain on top of their concussion, they're going to do poorly without intervention in terms of return to work. And so it's just really important to know what other associated injuries are there and how are we going to manage that proactively so that we get people back to work. So the other issue is this whole issue of effort and malingering and litigation. This has become a very hot topic in a variety of circles because people, it's a strange phenomenon, I think, but healthcare providers tend to, if they can't see it and they don't understand it, we love to blame the patient. And so in many cases, people blame the patient and say, well, you're just not trying. It's kind of like it used to be in the psychiatric world. If you're depressed, it was, well, just pull yourself up by the bootstraps. And now it's, well, please restore your neurotransmitters to their proper metabolic levels. So this issue of effort and malingering is an important one because some of our patients do exaggerate their symptoms. And indeed, when you look at the data, patients that are involved in litigation do read more about their symptoms. But to make matters worse is the stress of suing somebody makes their symptoms worse and may make them persist. And of course, there is the issue of secondary gain. But in the literature, if you look at the actual incidence of feigning or malingering cognitive impairments after concussion or mild traumatic brain injury, it's somewhere between 5 and 20%, depending on what study you read. So it's not that prevalent, but it's important to know when it's happening. Patients with inadequate evaluation or early assessment and education sometimes come into my office and they say, Doc, and they'll overstate their problems because they've gone to 5 different doctors. Everyone told them their CT scan was normal, therefore you shouldn't be having this problem. They may come in and they may intentionally magnify it so I get that they're having a problem. And that's a different kind of psychological process than in fact feigning or malingering an impairment. There are diagnostic criteria for malingering that include a volitional exaggeration of cognitive impairment for the purpose of obtaining material gain or escaping formal duty. So that's one criteria that has to be met. The other issue is effort is not a dichotomous variable, but a continuous one. We'll talk about that more in a minute. So if I ask you the question, do you put forth 100% of effort every hour of the day, every day of the week? And the answer to that is going to be no, because none of us do. And if you're sitting in an office all day getting, 600 neuropsychological tests, I can assure you that your effort is going to be somewhat variable. But it's not either good or bad. And then, although it bothers me a bit that a guy by the name of Slick published about malingering, but anyway, he put forth some really good criteria for definite, probable, and possible malingering. Unfortunately, those criteria aren't often used enough by the neuropsychologist community, but they're available, and we should be careful about making a diagnosis as we should in any diagnosis. So I'm going to bounce off of this because it's so in terms of this issue of effort, in fact, clinically, what we see in our patients there are some patients that'll come in and they'll malinger. It's a small group of people, but they don't have a problem, and they're gonna lead you to believe that they really do have a problem, which is different than symptom magnification, because this patient has a problem, but they're going to make it intentionally seem or appear worse than it is. Some patients are going to accept or have good awareness of their difficulties, and they'll represent it as it is. Some patients are going to minimize their problem. They say, yeah, my memory's a problem, but it doesn't really affect anything that I do in day-to-day life. And then there are those patients that are in frank denial and say, no, my memory is perfectly fine, doc, and I don't care what your test results say, there's no problem. That denial is hugely problematic from a recovery standpoint, and is just as important to be aware of as symptom magnification or malingering. And so, of course, what we try and do is get patients in the middle here, where they're aware and they're accepting of the impairment, and then engage in strategies to get over that disability. But those are some of the specific issues we get into. I'm going to bounce over this one so I can get in to these guidelines. So these are new, folks. They're provided by the Ontario Neurotrauma Foundation. What I like about these guidelines is that they based them on a variety of pre-existing guidelines that were developed by different associations, like the American Academy of Neurology, the American Congress of Rehabilitation Medicine, the Department of Defense and VA guidelines for mild traumatic brain injury assessment and diagnosis. They drove this not only on other guidelines that were out there based on the research, but then they also did their own systematic reviews of the literature. And these guys started out with something like 29,000 different articles about concussion and mild traumatic brain injury to develop these guidelines. It was a 5-year process. So they didn't pull these recommendations out of their ear, so to speak. They're incredibly well-founded in the science of assessing and managing folks with concussion and mild traumatic brain injury. So this is their second edition. They just did a new update. If you do a Google search on Ontario Neurotrauma Foundation, you'll easily find these guidelines. The guidelines are there for physicians, well, for all healthcare providers, about what needs to be done at each stage of the process. So let me just share some of these with you. So with respect to the initial phase of diagnosis and assessment, as I mentioned earlier, the earlier the diagnosis, the better health outcome the patient has. So the idea of, oh, it's just a concussion is really a bad idea. And so if there's a concern about that, get it assessed, and get it assessed according to the evidence-based guideline as quickly as possible. And we'll talk about that. Usually people end up, if they don't go to the emergency department, they go to their primary care physician. Irrespective of whether it's the PCP or the ED physician, they need to do a history, and we'll talk about that more in a minute. an examination. We'll talk about that more in a minute. They need to do a cognitive screen. They need to do a post-concussion symptom assessment. The one we're using is called the Rivermead. And they need to review their mental health status and history. So this is what these guidelines are saying is you can't just walk into the doc's office and say, oh, gee, let me check your reflexes. Gee, you're okay. You must be perfectly fine. That's not a concussion, mild traumatic brain injury assessment. Then the need for whether CT or MRI or CT needs to be done. And CT is the first line of neuroimaging. MRI may be indicated later, but CT is the first. So people that need a CT scan that are high risk that need a CT scan include those that are less than a Glasgow Coma scale of 15 for 2 hours at 2 hours post-injury. If you're 2 hours post-injury and you're at a 14 or 13, you ought to have a CT scan. If there is a suspected open or depressed skull fracture, you need a CT. And the symptoms of that are bleeding from the ear or hemotympanium, raccoon eyes, which is this dark area around both eyes. If you have cerebrospinal fluid leaking, which is a huge issue, so immediately you want a CT scan. And battle sign, and all of a sudden I am completely amnestic for what battle sign is. Okay, so Google it and you'll find it. Sorry about that. Any sign of basilar skull fracture, which can be some of the above, but there's other symptoms associated with that. Vomiting, interestingly, 2 episodes or more calls for a CT scan. And usually vomiting, yeah, there are anatomical reasons for that, but if you vomit more than twice, you need a CT. And I'm surprised that the age is 65 or greater, because, in fact, when you look at it, well, I suppose these are anecdotal data, but I certainly see patients more vulnerable to abnormal CT scans after the age of 40, but the guideline is 65, so I would trust that data more than I would my own anecdotal experience. But that's when you need a CT scan. The medium risks for CT scan, if your retrograde amnesia is 30 minutes or greater. Again, for those of you, retrograde amnesia is that loss of memory prior to the injury. So you remember leaving home, but you don't remember going to the grocery store or to the gas station. And then 10 minutes later is when you got hurt. So that's a retrograde amnesia. Interestingly, the mechanism of injury also influences this guideline. And again, this is why we have evidence-based reviews, because it's driven by the data and the statistics. You wouldn't necessarily think that this would be a risk factor, but it is, and that is being struck as a pedestrian or ejected or falling. So if you notice this, all these dangerous mechanisms are that you're falling or there's a blunt force trauma where you're ejected from the vehicle or you're going to hit the ground or the pavement or something. The other thing that's really important, and we're just now starting to do this in our emergency departments, some of them anyway, and that is standardized measurement of post-traumatic amnesia. So right now, the way we assess that is we'll sit down with the patient and say, okay, well, gee, what's the last thing you remember? Which is kind of a funny question to ask if you think about it. But so we'll say, okay, well, you remember leaving home that day, right? Right, yes. It's not what people have told you. You actually remember leaving home, right? Okay, right. And then you're going to say, okay, well, what's your next memory after that? Well, how do they know in time, if they've been unconscious or they have this period of post-traumatic amnesia, they may remember some event. They may remember Aunt Millie coming to the hospital room or something, but it's pretty sloppy. And there are indeed standardized instruments out there. One is called the Rivermead. It's another one. And then there's another measure called the Westmoreland, actually. And so you can administer this instrument. There's also one called the orientation log. And you can administer that every hour. You can administer it every 6 hours. You can administer it 5 times a day. You can administer it as often as you want. But what you get is now very precise data about when does the patient start to form new memories. And that's, again, helpful from a prognosis standpoint, an assessment perspective, severity of injury. And so when they looked at all the research, the better the diagnosis, the better health outcomes. And part of that diagnosis is the duration of post-traumatic amnesia. So specialized emergency departments like the one at Methodist or St. Vincent's, but especially Methodist, are much more likely to have these sorts of specialized assessments going on in trauma. Now I'm going to shift a little bit here to the treatment issue and why the assessment is so important, although we're going to come back to assessment here in just a second. But what the research also shows is that when we start working with these patients, you want to start with treating their depression, anxiety, and irritability, their sleep impairments, and their headache. Those are the first issues you need to address. If you do, you're going to get a better long-term outcome. Secondly, if the patient persists then in having difficulties with balance, dizziness and vertigo, cognitive impairment, fatigue, and tinnitus, then address those. But first, you've got to start off with these primary symptom disorders, and some of these treatments are pharmacological. So maybe antidepressants or anxiolytic antidepressants. You may want to treat the irritability. Sometimes we treat that with psychotropics like antidepressants, and sometimes we treat that with stimulants, depending on what the source of the irritability is. Treating the sleep disorder is important. Getting people to sleep well is a really important issue. So sometimes we use trazodone, for example, to help them sleep. And interestingly, if you help them sleep better, then they're more likely to be awake, fully awake during the day. And treating headaches, because not only headaches are debilitating in terms of pain, but they're debilitating in terms of their effect on cognitive and behavioral status. So treating these primary issues first is what the evidence would suggest. Now, in true concussion, mild traumatic brain injury, as we've seen from the data, the majority of these patients are going to be fine in 3 months or maybe a bit longer. As a consequence, what we want to do is we want to prevent comorbidities. So you know, of course people get scared. Of course people get freaked out, especially when there's crummy diagnosis and they're getting no information about what's going on with them. So it's important to prevent these complications. It helps them with their relationships. It helps them with their return to work. It helps them with managing their kids. It helps them with life. So in the early intervention with these patients, it's important for them to know that yes, these symptoms are normal, not for you, but they're normal for you now because of what happened. They're going to get better, and more than likely, by a significant majority, you're going to be perfectly fine. And a fellow by the name of Mittenberg developed or did a number of studies and looking at how to manage this early recovery, and he developed a patient education booklet, which I have, and it simply goes through all the symptoms. It's encouraging. It provides information to the patient. It helps them notice when they're getting better, because when you think about it, if you're scared and freaked out about your symptoms, you're going to pay attention to your symptoms, not to when you're doing better. You're not going to notice when you're doing better. Moreover, it's hard to notice when you're doing better because you live with yourself every day. But in a variety of studies, this simple patient education booklet significantly improved recovery. And so So the patients need to be educated about their injury. They need to be given written information. They need to be encouraged to read that. The family needs to be encouraged to review that. And if that all goes well and it's an uncomplicated mild traumatic brain injury and concussion, most folks are going to be fine. There are, of course, though, patients that come into the concussion with comorbidities already on board. So what? 40% of our population has an active and untreated anxiety or depressive disorder. So if you're anxious and depressed, and then you get your concussion, you're less likely to improve so quickly. So it's important to identify that, and then if you have symptoms that last for more than 3 months post-injury, that's when you need to be seen by a specialist concussion mild TBI team. That's what the guidelines are advocating at this point based on all of the outcome research. So educate them for the first 3 months, provide support in the first 3 months, provide accurate diagnosis and assessment. And if they're not better at 3 months, then that's when you need a specialized team of people engaged. So this educational material that I was telling you about, developed by Mittenberg, has got several components. It includes the symptoms as expected. Oh, I'm sorry, that should be as, not an. Symptoms as expected outcomes. So yes, I know you've never had dizziness before, but you've had this concussion. It's going to get better. It's significant probability that you'll be perfectly fine in 3 months, etc. Normalizing the symptoms, that is, it's specific to what has happened. Reassurance about the recovery. This issue of gradual return to activities and life roles is a hugely important issue. And techniques to manage stress. So the return to work process after a concussion, mild traumatic brain injury, gets mucked up more often than it goes well. It depends on the nature of the job, how much cognitive activity, how much physical activity is required, how much experience does the patient have doing that job. In all cases, return to work, if it's possible, should be gradual. Because what they once found easy to do in a day will be exhausting for them. If the employer can, if there's no way the patient can go back to work part-time, then the only way to manage that proactively is to build up their activities off the job to a point where then they're cognitively and physically ready to return to work full-time. It's hard to simulate that, and it's the less desired strategy, but and this is true for all brain injury, but this titration process is really important. So I had this one patient who was a young guy, and he had a concussion, or he had 2 concussions actually, and he was just desperate to get back into school. And so I gave him some recommendations in terms of some cognitive activity to do at home to kind of help get him going. And unfortunately, either I wasn't clear or he wasn't listening, but he went home and flew himself into 8 hours of cognitive activity a day, because in his mind, the more he worked at it, the faster he'd get better. And of course, the exact opposite happened. When I saw him back the next week, he was considerably worse cognitively because he'd absolutely exhausted himself. And so titrating people back to work needs to be done carefully. I've got a patient that had a severe traumatic brain injury that I've been titrating back. She actually resumed her job last July. And in 3 weeks ago, I just released her to work full time. So it took us, 7 months to titrate her up. And what happened is I tried to increase her earlier, but then she got symptoms again. So I'd have to back her down. And then she got better. And then so we crank it up again, and she tolerated it. And then we crank her up again, etc. But it has to be careful. And this woman's now 18 months post-trauma, but she had a severe head injury. But it's not different in concussion and mild head injury. It's just usually sooner. So this titration back to work is a delicate issue, and that's why we often follow patients pretty closely during that period of time. And I think I said this earlier, at 3 months post-injury, if the concussion mild head injury patient is still having cognitive symptoms, then they need a formal neuropsychological assessment to get the right treatment recommendations. What can come out of that assessment in terms of rehabilitation interventions? The first is, of course, cognitive rehabilitation. And there are evidence-based guidelines out there published by the American Congress of Rehabilitation Medicine about what effective cognitive rehabilitation strategies there are. Stress management and psychotherapy may be a part of that to help patients relax and get control of their symptoms. As I said, titrating them back into all kinds of activities. Maybe it's parenting, maybe it's their recreational activity, maybe it's work. And then a number of these patients come into a brief trial of resource facilitation to help them return to work, as many of you know. So these are some of the rehabilitative interventions that may be appropriate. I see there's a question coming in. Where did you say that we can locate cognitive activities? Okay, so thank you, Sandy, for the question. So the evidence, the research. So I'm going to give you two answers to that. First, I'm going to give you the evidence-based answer, and that is again, the American Congress of Rehabilitation Medicine has published 3 different articles on what cognitive interventions work, and there are practice recommendations. And if you want more information about that, feel free to email me. Based on those recommendations, a number of us put together, and I've not shared any of this with you guys as yet, we put together a new cognitive rehabilitation manual, and it's published by the American Congress of Rehabilitation Medicine. I'm the managing editor, and there are 5 other authors to that manual, and it very simply is a manual that takes the evidence-based recommendations and gives therapists very practical strategies. I won't say it's a cookbook, but it is do this and then do this and then do this. It's pretty fundamental, nuts and bolts. Here's how you treat memory problems. Here's how you treat attention problems. Here's how you treat executive function impairments. If you look on the website of the American Congress of Rehabilitation Medicine, you'll see a page on the manual. And we've been doing workshops all over the place on this, and so people are finally starting to be aware that there's evidence-based practice available for treating these kind of problems. Now I'm going to step into a slightly different domain. So yes, there's products out there, for example, like Lumosity, which is a web-based cognitive, I think they call it cognitive training website. I think it's still controversial. There have been some studies done on Lumosity. The findings are unclear as yet. I think that there are some promising findings, but under very specific conditions. I think that the other issue is that we always have to be really careful about managing this issue of the therapeutic relationship. If all of a sudden your wife is trying to treat your memory problems, a lot of guys are going to have problems with that, and vice versa probably. I think oftentimes we need a therapist for that human interaction to deal with those issues. And so I think we have to be really careful about spouses, parents, kids, whatever, trying to be therapists. It's sort of a therapeutic alliance or relationship issue. The other comment I want to make is that any cognitive activity can be managed and titrated. So So in terms of home-based activities, I think if being properly guided, you can use a crossword puzzle. You can use a website or the web. You can use anything and sort of carefully manage return to functioning if it's managed appropriately. So and that's true for physical activity as well, you know, so and the rule of thumb is if you make the symptoms worse, you did too much. Again, it's the opposite. Sometimes we say, well, if you know you twisted your ankle, you know, you don't keep using your ankle until you can't walk, or you shouldn't. And the same is true for cognition. So if you make the symptoms worse, you're doing too much. So I think that any cognitive activity and gradually resuming that activity can be therapeutic and help build their stamina. So I don't know if that answers your question, Sandy, but it was kind of a long-winded answer. So, okay, so we're just getting ready to roll out a new concussion mild traumatic brain injury service, and I just want to share with you what that looks like. So the initial level of this, based on the evidence, is this triage based on these 3 symptom categories that you saw earlier, whether they present with cognitive, emotional, or physical symptoms. And usually most of these patients present with all 3. But then based on the initial triage, they'll either go to a specialist physician or they'll come to one of our neuropsychologists. Now notice that neuropsychological testing doesn't occur, may not be necessary, and if it does occur, it'll only be at 3 months if they're still symptomatic. So if they have cognitive or emotional changes associated with their concussion, then we will provide that educational material to them. We'll help them, give them some relaxation training strategies they can use at home. We'll offer them reassurance, and we'll follow them to make sure they get better and encourage them that they do. If they have physical symptoms, headache, nausea, dizziness, then they're going to be seen by one of our physical medicine and rehabilitation physicians who specialize in head injury, so that they get evidence-based assessment and accurate diagnosis. Depending upon that evaluation, they may go into vision, further vision evaluation if they've got double vision or some kind of visual change. If they have balance or dizziness or fatigue issues, depending on where they are, they may get some physical therapy. They may get some medication for a headache or additional diagnostic studies like CT if necessary and the like. So we're going to assume then that this patient is going to do well, and at 3 months they're going to be fine, or 3.5 months. If they're not, then that's when we'll do neuropsychological testing, and depending upon those test results, then they may go into one of these interventions for rehabilitation that came out of the evidence-based reviews. So that's kind of the overall system that we're just getting. In fact, we're going to roll this out on March 27. I think that's the date will be the rollout on this. But if you want information about these guidelines, send me an email, or as I said, it's the Ontario Neurotrauma Foundation. If you Google that, you'll find all the details. And in that manual is explicit detail about what goes into each assessment at each time point and when it should occur, so we can get our folks the best outcome. So that's what I wanted to share with you today. In summary, 85% approximately of these patients are going to be fine at 3 months. There's a huge number of pre-existing and post-injury risk factors that are going to influence that recovery. Early assessment and proactive education and management improve outcome. And then if at 3 months they're not, then that's when you need to get aggressive with their rehabilitation and management. So we've got some time for questions. if you want to talk about brains or you want to talk about, well, I don't care. We can talk about anything. Please feel free to fire questions at me if anyone has any. I can sing to you in the interim if you'd like, which may promote you asking many questions quickly. I don't know. Yeah, no, Wendy, I'm not going to really sing. So, yeah. So, but I will when I come out to the office later. Yeah. So I see Shell is sending a question. Hi, Shell. You must have a long question, Shell. Here we go. I'm running into males who are intervention resistant. That's interesting. I need more data, Shell. What do you mean intervention resistance? You mean they don't want? Yeah, okay. So they don't want treatment. I gather. Is this an issue of denial? If it's denial, and I'm going to assume until you want to deny the symptoms related to TBI, right? Okay, yeah. So that's not terribly uncommon, and unfortunately, it's associated with not a very good outcome. And so I think if you have to think about something, Shell, yeah, when they're obvious to everybody else, right? Right. Good, beautiful question. So let's think about denial for a second. So what motivates denial? Because all behavior is motivated. If the question is by what? And so even though a behavior may not be adaptive in the long run, like denial, it has a purpose. And so this person is denying for a reason. So the question is then why is that individual denying? What's motivating that? Well, in most cases, and I see you're typing, so that's terrific. Thank you. In many cases, denial is motivated by fear. So the presence of that symptom scares that person. It threatens their feelings of adequacy. It threatens their feeling of being in control. It threatens their ego. And so I'm going to deny that symptom is present because I find it intolerable. It's too ego-threatening. So I see you wrote, I had thought about that. I think it is a lessening of their impression. Exactly. So that's correct, Shell. So it threatens their sense of what we call efficacy. So self-efficacy is a really important construct in understanding these folks. So efficacy is when you walk into your office, you have a certain sense of efficacy, that is, your ability to manage and take care of your job that day. And if you've got a strong sense of self-efficacy, you're going to find it fairly stress-free. Well, that may not be true. At least based on what you have control over, you may find it stress-free. You may be confident about your ability to do it. You may actually execute it in a really good way because you walked in there believing that you could manage or take care of the situation. And yet, on the other hand, individuals that have poor sense of self-efficacy have a much harder time of recovering. And what my colleagues, Dr. Backhouse and Ibarra, have looked at is that if you look at self-efficacy, they're much more likely. You can train people to acquire a sense of efficacy to manage brain injury problems. So if you teach people that they can manage these problems, you improve their self-efficacy, and therefore they get better. But anyway, so back to this issue of denial. If it's ego-threatening, then so what that patient needs who's denying is reassurance and education, which is the last thing that you would think initially. But often what we need is often the opposite of how we behave as a species. So this patient that's denying if you intervene with them and their family and say, look, I understand that this is really scary for you, and it's really unlike you to be scared because you're a tough guy most of the time, but now you've got these problems and that scares you, and that's really difficult to face, but I know you can do it, and I know that you'll learn how to master this situation if we can get on with some interventions that'll help you out. And so in other words, you're taking the denial and you're flipping it over and reassuring them that they in fact can come to conquer the situation, and therefore you're going to feel powerful and in control again. And it's of course takes more words and more time than what I just said. But I think the underlying message is it sounds like you're dealing with some folks that are in denial, that find that too ego-threatening, and they need reassurance that they can learn to overcome this, and that they can resume their ego identity, if you will. They can resume their activities, their roles, their usual, or they'll find a way to. Then they may be more amicable or flexible in responding to your recommendations. If you're talking about a patient with a severe injury, and they're never going to assume some of the roles and activities, then that's a different story. Then sometimes you have to say to people, no, this isn't probably going to happen. You may not go back to work, but you can discover other kinds of life activities or roles that are going to be satisfying. But that's an even longer story. So that's how I'd respond, at least initially, to that question, Shell. I see you're typing away again, so we'll see what comes in on that. Are there other questions out there amongst you? Okay, so Shell's got another comment here. So you are assuming that they will hear me, right? They refuse any service. Is there a follow-up program for patients? So it's pretty common for myself and Dr. Backhouse and Dr. Ibera to follow our patients long term, to do follow-up, because we know that sometimes they're refusing treatment, and we also know that it's likely to get more difficult as their denial persists. So we may see them every month, we may see them every 3 months, we may see them in a year to follow up with them. They may not want to come back, but their families usually bring them back. But other than that, I'm not aware of any other systematic follow-up service. Unfortunately, most of the time people are just pushed off the cliff, and that's the end of that. But that's at least how we're managing our patients. So.
They're enrolled in TBI model systems.
Yeah. Okay. So there is one other issue. That's right. So as part, since RHI is part of the Traumatic Brain Injury Model Systems grant, they get systematic follow-up for life, I believe. It may only be once every year or something like that. There's a standard follow-up protocol for that system, and we're one of 14 centers in the country following patients like that. So, and if they do have clinically significant difficulties, I think they refer them then to appropriate follow-up. So yeah, that is one other process for following these folks. Other questions? Yeah, you're welcome, Shell. Good question. Other questions out there? It doesn't appear so. So I've exhausted all of your neurotransmitters, and you're ready for your espresso now, which I think I am too. As always, I appreciate your engagement in these things, and please send me ideas that you would like future webinars to address. We're going to get together and put the next year of webinars together in terms of topic, so it would be really timely if any of you have requests in that respect. So, as always, thank you very much for your participation, and goodbye from Radio Free VR. Take care.
Oh, wait. Oh, thank you. Okay.